It's just pathetic.
The average cost of just getting 40 hours a week of care at home for your aging parent is now pushing north of $82,000 a year.
Yep.
It's going up at triple the rate of regular inflation in our society. And I think if we don't solve it as a society, millions of people in the prime of their careers are going to burn out and quit their work to take care of their aging parents.
I don't know that we can confidently say that this country is ready to handle that demographic wave. Hopefully we can figure it all out before the system just totally crashes.
Have questions about your healthcare and not sure where to turn? We give you unfiltered insight into how healthcare really works. This is Give It To Me Straight Doc, presented by Tampa General Hospital and our partners at USF Health Morsani College of Medicine.
Welcome. You're watching Give It To Me Straight Doc. I'm your host, Anjalee Khemlani, and we have a show for you today focused on aging. It is a broad topic. I know, Neil, you know all about this. Neil Shah, CEO of caregiving, thank you for joining us. I'm going to launch right in because you and I have already talked. If anyone recognizes him, he's been on our show before. You're going to be our sole callback guest because of how awesome you are.
Thank you.
But Neil, we have a serious topic to talk about today.
Yeah.
And that is aging in America and all the parts that go and fit into it. And the thing I really want to talk about with you is caregiver burnout. I mean, we know that all the people that are aging, we have a silver tsunami, as it's called, of a mass volume of people entering old age. And so the burden is falling on what is known as the sandwich generation, Gen X and older millennials. We've seen the burden that they face in having to take care of their folks without direction or resources. And I feel like technology is now filling in the gap, right? With generative AI, search engines, AI companions on the market. But there's a lot more that goes into that. So I know this is something you're studying and focused on. Talk to me about it. What do we need to know about this issue?
Sure. So first of all, the size of the issue. You know, the average person caring for an aging parent is spending over 22 hours a week on the care. Think about that. Most of these people are middle-aged, like people like you and I, or maybe up or down 5 or 10 years. People are managing full-time jobs, oftentimes caring for their own children. And add that to on top of 22 hours a week caring for your mom or dad, taking them to and from doctor's appointments, going over to their house, checking on them. Unpaid, yes, unpaid. It's over $1 trillion. So I think the scope of the challenge is very large. Over 60 million people are in it. It's $1 trillion of equivalent economic value. I personally think the number is actually a gross underestimation. I've done my own research on our own caregivers that we talk to, and I think the number is closer to $3.5 trillion.
Wow.
Because people up and down the income spectrum are doing it. So the opportunity costs of their time. It is a massive challenge. And I think if we don't solve it as a society, millions of people in the prime of their careers are going to burn out and quit their work to take care of their aging parents. Or millions of older adults are going to end up on their own without care. And I think both of those are tragedies.
I'm glad you brought up the economic part of it because that plays a huge role. If you have a job where you're comfortable, you can afford to either take time off comfortably because of the benefits you have, or you have the income level and the flexibility of your work schedule to be able to do it, then that's better than just those folks who are living paycheck to paycheck and don't have the ability to then take on that additional burden. And you see the dynamics too in families, right? There are families where it's multi-generational in one home and that kind of helps ease the burden, but it also adds to it. So it's just like double-edged sword here. I think the question that we're facing, with America is how do we then solve that problem? Because it seems like the U.S. healthcare system is not equipped to handle this problem.
I agree. And it's because it happens outside of the healthcare system. So most of the long-term care of older adults happens at home. Some happens in a facility setting, assisted living or skilled nursing, but the vast majority is happening at home, done by family members. And let me tell you, the cost of that is insane. The average cost of just getting 40 hours a week of care at home for your aging parent is now pushing north of $82,000 a year. Yep. It's going up at triple the rate of regular inflation in our society. When you do the math, you got to earn 130, 140K, pay taxes on it, and then spend that money. So the pre-tax income level required to get care at home for your aging parent is so high that most people would be like, I'm just going to quit my job and do it myself, which to your point perpetuates inequality in society because people of less means will end up taking the career hit doing it on their own and then try to get back into their career 5 years later, and who's going to hire them? So yeah, I think it's a big challenge. And a couple of forces that I think people are missing is the demographics of our country are heading in a direction which is leading to skyrocketing costs. Our society used to be like this, a pyramid, where you have a ton of young people, a bunch in between, and then very few old people. The ratio of middle-aged people to older people in our society is about 7-to-1 for decades, right? So if you think how many people are for each person that needs care, on average, there's 7 people in society to care for them. This decade, it's collapsing to 3-to-1 because our pyramid is going like this now. There's fewer young people, not that many middle-aged people, and a bunch of older people. And many of them are going to need care. So I think it's the first time in history, by 2030, we'll have more people above 65 than below 18. First time in recorded history.
And this fuels the conversation, right, about having more people burden the system than with needing the social safety net programs, in addition to the whole, population crisis, as some people call it, the focus on population and reproduction rates globally. I mean, this is not even just a U.S. problem; it's a global issue.
It's a global problem, and to add to that, immigration. So think about the demand for care is skyrocketing with the baby boomer population aging into the years of 75 and 80 plus. When your long-term care needs skyrocket, demand for care is skyrocketing. People are living longer, but not necessarily fully able to take care of themselves in the last few years. And the supply of care is collapsing because you don't have that many middle-aged people. A lot of people don't know, after the baby boom, there was a baby bust.
Right.
So in society, with the rise of birth control and, marriage rates declining and people getting married later, there's been a collapse in birth rates from 1970 onwards. So post the baby boom, there aren't that many middle-aged people to take care of these people. And now we have massive immigration tightening. So that was going to be the one kind of fallback. So yeah, it's going to be a challenge. Who's going to take care of all these people? In most
AI
markets,
robots. I have the answer.
There's a shortage. What's that?
AI robots. That's who's going to take care. That's what I'm.
Yeah,
that's
I mean,
what I'm
AI
betting
maybe,
on.
but the robots are years away.
I know. But I'm hoping for my lifetime.
Maybe for us.
Anyway.
Right now, the robot can't even hold a glass.
Yep,
have you noticed
true.
that? They're breaking glasses when they're trying to fill the dishwasher. So AI is cool from a text and LLM machine learning kind of language perspective, but physical world learning of AI and robotics has a long way to go.
Sure.
I mean, it's all hype right now.
Yeah. Well, Neil, thank you for joining us once again. Neil Shah, CEO of Care. Don't go anywhere. More on aging next. Welcome back. You're watching Give It To Me Straight Doc. I'm your host, Anjalee Khemlani. We've been talking about aging in America today, all the places where we find the holes in the pitfalls, all the resources that are increasingly available. And one area of this aging population, this silver tsunami, as it's been called, is hospice and palliative care. And that's something that Amy, you know a lot about. So I'm bringing in Amy Abernathy. She is the co-founder of Highlander Health and a former FDA Deputy Principal Commissioner. So Amy, thank you so much for joining us today.
It's great to be here with you. Thank you.
So hospice care, palliative care, these are terms that people think of synonymously with just end of life period, right? And just managing sort of symptoms. But I think increasingly we're in a world where that is actually a longer ramp, and patients don't necessarily know that. And I wonder if in part it has something to do with the fact that the way that we interact with the healthcare system and the way that the U.S. healthcare system is set up sort of de-incentivizes that. Would that be a good way of framing it?
So hospice and palliative care, and this question of does the healthcare delivery system incentivize it or not? And how are we going to think about it? First, let's step back and ask ourselves, what is hospice and palliative care about in the first place? The underlying philosophy is that in order to take care of people with serious illness, especially serious life-limiting illness, that we need a combination of focusing on the disease or the biology, plus focusing on the social needs of the individual and his or her family, plus in focusing on the psychological needs, so the mental health needs and other aspects of our whole self, and also focusing on symptoms and existential needs. So this kind of overall thesis of biopsychosocial care, and how do you blend among those to get what this individual needs, especially at a time when there's just such heightened emotions, such heightened challenges with disease symptoms.
Yeah.
We have two kind of areas of focus. So hospice care, which really is this idea of being able to make sure that for people, especially in the very end of life, have the right combination of symptom control, support at home, and all of the elements that might be needed. And then it is often distinguished from palliative care, which is the clinical provision of biopsychosocial care itself, maybe earlier in the disease than just at the last moments of life. Interestingly, this split between hospice and palliative care largely came about because at first there was a Medicare decision to cover basically this biopsychosocial care model in the very end of life under the auspices of the hospice reimbursement mechanism. And that then limited really to the last 6 months of life. And then there's some mechanisms to allow for some adjustments. But it was a Medicare approach in the very beginning that created a reimbursement environment that then created this definition of hospice being more for people who are closer to the end. But then you sort of say, well, what if you're not all the way at the end, but you still need this fuller set of services?
Right, yeah.
And that typically is what we think about with palliative care.
That's interesting.
The last thing I'd say is that, you often sort of see that it's possible to get access to hospice at end of life because there is an aligned reimbursement mechanism. But it's hard to get access to palliative care services. Service availability is spotty. Reimbursement models are unclear. It's unclear about what to do if a person is not necessarily, dying in any near or intermediate term, but has huge problems with symptoms that might be overwhelming everything else and might not necessarily be clearly in the purview of any other type of doctor. And so this is one of the things that's very complex.
It is. It's so complex, and it's just as complex as a person's biology. It's just as complex as the healthcare system we have. I want to get back to this in a second, but that tongue twister you keep saying, biopsychosocial. Okay. Talk to me about just explain the term as briefly as you can.
Yeah, so the general underlying care philosophy is that we are a combination of multiple elements as human beings that each need to be separately addressed, but also in combination. Sometimes you might need more focus on one thing and no focus on everything else, but that includes the biology of the disease. So that's the bio. Our overall mental health and well-being. So that's the psychological. And also our social milieu. So like things that happen within the context of our family, as well as our existential needs. Oftentimes, when a person is dealing with a health crisis, there's also the existential questions and questions around faith that are also part of this overall construct of care. And so the language around it is the biopsychosocial care model.
I can't believe
but
you
really
keep saying
it's
that
the blending
fumbling
together.
I love that you say it without fumbling. Oh my gosh. Wait, no, but I know it's a serious topic. I'm sorry to derail it, but I think that's fascinating because I think part of the problem has been that people think about the health system as being fragmented and fragmenting the care just by way of focusing on specialties, focusing on one part of the healthcare journey rather than altogether the way you're talking about. Back to that palliative care part, you're right, it is spotty. I mean, I've shared with you candidly that I have experienced this in my own parents' care journey and found that it's not even just spotty, it's I mean, I don't even know what the word to use for it is. It's just pathetic. The idea that we are trying to set up a system that is ready to take on this wave of people who are going to need these services, and this is the level of service we have. I don't know that we can confidently say that this country is ready to handle that demographic wave.
Yeah, so I think this is a really important conversation for us to have. So, when I first started in the palliative medicine space, my first question really was, does the biopsychosocial care model actually have positive impacts on patients and their family? And so between the 1990s and the 2000s, a number of studies were done that reinforced this overarching understanding that indeed palliative care makes a meaningful difference in improvement in quality of life, can also potentially improve survival. So you can imagine paying attention to the things that matter for a person with serious illness actually makes a person's pain improve, makes a person's sense of confidence in what's happening to them day to day improve, and therefore their psychology and their interface with their family. That improves quality of life, and also then maybe even improves their ability to tolerate the biological treatments that they're getting for their disease itself. So there was, an expanding literature about the role of palliative care. But what's interesting is that it was not easily matched with what's the care delivery model that allows that to be reimbursed. It's clear how we reimburse the costs of an oncologist, and I'm an oncologist as well.
Right.
So it's clear how to reimburse for oncology care, for chemotherapy. And I'm not saying any of that is wrong to do. It's that, in a healthcare delivery system that's constrained and where we're trying to constantly tamp down costs, adding new things in has been hard to do. And figuring out the best mechanisms to add in palliative care delivery has been hard over time outside of that hospice frame.
But you and I have talked about how the right model to incorporate all of it does exist, but it just is in a different space. And my suspicion is that if you follow the money trail, that's why.
Yes. Well, so it's interesting. When I describe the biopsychosocial model, it's pretty easy to say, well, yes, of course, we are naturally, as human beings, a blending together of biology and psychology and existential needs and our social welfare. And in fact, we've been getting better and better as society at talking about this. And it's also interesting in that 2026 and going forward, we have an emerging number of care delivery models that are starting to put these elements together. So for example, even in the longevity space, there is
huge
increasing recognition, right? Totally huge. So increasing recognition that in order to live longer, healthier lives, we need to have preventative healthcare and preventative health maintenance. We need to make sure that we understand the individual diseases we personally are experiencing, but we're also taking care of our joints, taking care of our cardiovascular health, et cetera. But we also understand, by the way, we need to have friends. Yeah. We need to have social connections. Family is important. It turns out that you live longer if you've had a disease and a spouse. So we now understand more and more in the longevity space that indeed this combination of attending to all the spheres of life actually turns out to be now improving quality of life and length of life. But we also, in the longevity space, are starting to develop models of how that gets paid for. Paying for the supplements, paying for the gym membership, paying for going to a longevity health clinic. Now I'm having a hard time with the words.
It's okay. You did good with the other one. We'll give you one freebie.
No, it's interesting.
Yeah,
right?
it is. And it's interesting because I think to kind of thread it all together, you mentioned the longer lifespan with a spouse, yet that we just had another guest on talking about the burden of caregiving. And so it's this like the seesaw almost, and we're learning the process together. It almost feels like for how to provide better care broadly in the U.S. system. So I think, learnings are there. To your point, we'll definitely have to keep a watch and see how it progresses. Hopefully we can figure it all out before the system just totally crashes. I hope. I don't know.
We have work to do, but the thing is that we have the seeds of now evidence that's pointing us in this way. Well, here's what we need to start to put together.
You're way more optimistic. We'll leave on that note. I love that one. Amy Abernathy, co-founder of Highlander Health and former FDA Deputy Commissioner. Thank you so much. Don't go anywhere. More on aging next. Welcome to Give It To Me Straight, Doc. I'm your host, Anjalee Khemlani, and we have got a show for you today talking all about aging and the many aspects that we see when it comes to aging. We know that the country is facing a silver tsunami, and that is something that means that as Erin knows, a lot of older people are starting to come in through hospitals. Erin Hill, here with me, is a case manager at Tampa General Hospital. Erin, thank you for joining us today.
Thank you for having me.
Of course. Listen, Erin, I know that there's a lot going on day to day in hospitals, right? Patients see so many different providers and nurses and clinicians and specialists and lab technicians. The list goes on. But one of the people that they see when they come into a hospital is a case manager. And they often don't think too much about what that role is. But I've personally experienced this, and I know that it's a very important role when you're trying to make sure that there is someone that is looking out for the patient and making sure that they don't end up coming back to the hospital sick, right? That's one.
Yes.
And then the second thing, if I have this correct, is that case managers basically have to figure out how to make sure that patients are going home not feeling lost in the system. Which is hard because have you seen the U.S. health system today?
Yes.
It's pretty large and complicated, right? So tell me from your perspective how you manage that, especially if there isn't even much of like an appreciation for what you do.
So what we do, we have two teams. There's case management and there's social work. Social work partners are more so for community resources, housing, food, things like that. Us, the case managers, we help you go through the medical portion. So like if you need rehab, skilled nursing, home health, long-term acute care hospital, we try to make sure that you have a roadmap to be able to discharge home and not have to return back to the hospital. So one of the things we do that's big is we do assessments. So we talk to you, we kind of get a little intrusive. We want to know all your business, how much money you got, what insurance do you have, what services can we provide to assist you from not coming back to the hospital to prevent the readmissions.
Do you feel like people understand your role, or when you come in that they're willing to engage with you, understanding that that's the value you're bringing?
In the beginning, no. Okay. Everyone's like, why are you talking to me about my money? Why do you want to know what's going on in my house? And we have to explain to them, you have a medical condition. We're trying to make sure that you have the appropriate services in place so that you're able to go home and be successful and not have to come to the hospital. I know you might want to see my face all the time, but we want to keep you as home as long as possible.
And that's the goal, right?
Yes.
Now aging is all about staying in home, not being an inpatient, not staying for too long at the hospital. All the reimbursement mechanisms through insurance, through Medicare, et cetera, are geared towards people aging in their home successfully.
That is correct.
We also have more technology to help with that. So how do you find that, patients who are on the elderly side, how do they manage? What are you seeing are maybe common themes that keep coming up and things that you think patients need to keep an eye out for?
First off, insurance. Insurance is the biggest thing because that's going to dictate your funding and what you're able to do. Some insurances allow for, a lot more things to be able to age in place, and some insurances, they don't. And then that's one of the things that we have to discuss and identify when they're at the hospital and talk about what can we do and what can't we do. Our social work partners are really good because they come in and they have resources on like different programs, like the GUIDE program, allowing for caregiver hours to be used at home, post-hospitalization. They also have resources in the community to help with disability, Medicaid filing, long-term care. So it's like both of us work together as a team to ensure that we're providing the correct level of care for that patient and trying to help them manage outside.
And trying to help them find the programs that exist that they don't know about. We don't know about what's out there. You do. That's your expertise.
Yes.
But the system we currently have, broadly U.S. healthcare, the problem has been that there are holes in that system. It's not perfect, right? You're going to find cases of patients that come in that don't fit in the right bucket, or they're not going to be able to fully maximize any kind of program. How do you deal with that?
We have, again, assessment and discussing, and there's knowledge base between us and case management and social work. So my previous history, I was a social worker before I became an RN, and I know a lot of the community programs, and I know a lot of things to navigate, especially in Florida healthcare systems. Now, the other states,
not so much.
Not so much. But we are the experts. We try to give as much resources and we try to discuss with the families what the next steps are going to be, what they need to follow up on, who they need to call, because you're correct. When you come to the hospital, this is the most tragic moment of your life. You're trying to get your mom and dad together. You might be coming from out of state. Like we've had patients that come from families that come from out of state, the snowbirds and things like that.
Right.
And trying to navigate those things. So it's just having that conversation, that discussion, and talking to them and seeing what we can do appropriately for them.
That's really good to know. It's good to know that you're there and looking out for folks. Everyone just call Erin whenever you're in trouble. We should just have you give your phone number out. I'm kidding. Don't do that. Erin, thank you so much for your time today. I think that, understanding the role of case manager will help patients actually seek them out more, rather than you having to constantly be proactively getting in everyone's business, like you said. Thank you. Erin Hill, case manager at Tampa General. Thank you for joining us. I've been your host, Anjalee Khemlani. You've been watching Give It To Me Straight, Doc.
And we're here to hear from you. If you have a medical question you've been unsure about, ask us. We feature real questions from real people on the pod.
Don't forget to join us next time, and also don't forget to scan that QR code on your screen.